This is microscopic picture of invasive duct carcinoma. You can see this is speculated mass. You clearly invasions are there. Okay, so on the microscopic slide, what we get? Irregular and complex duct or gland-like structure or small nest or cord of neoplastic cells. So cells are arranged in the any form. They are maybe the solid, they form the nest, they form the cord, they may be present in the commado pattern like we discussed in the in situ carcinoma. So we get any type of the pattern in cells. So they are surrounded by the dense collagen stroma in between the cells. How we say is a malignant cells, so you have to get the specific nuclear finding of the cells. First, nuclear enlargement, pleomorphism, prominent nucleoli, frequent mitotic activity, and no epithelial cells there. This is very important. So you can see here this pleomorphic. The cells are arranged in the cord-like structure, or say arranged in the ductal structure, or sometimes they form the solid nest. There is malignant pleomorphic cells are there. Here in this picture, the high power view, you can easily see here in this the large blue nucleus showing the marked pleomorphism. Some are very small, some are very large. In this few of the nucleus, you can see the nucleoli. What is nucleoli? Inside the nucleus, you can see the small dots. These are dots are nucleoli. Okay. Increased abnormal mitotic activity. How we see detect the mitotic activity? The nucleus, when the nucleus become a irregular in shape, there is a straight line, or they form the Y-like structure or irregular figures inside the nucleus. This is known as a mitotic figure, and this surrounded by this fibrostroma, and you can see the malignant cells inside the fibrostroma. Means there is an invasion. Normally the cells are present inside the basement membrane intact, but here the basement membrane is not intact. You can see the invasion of the cells inside the stroma. So if you get all these findings, the cellular changes, malignant cells with the in this here in this corner, I'm giving you this taking this into the corner. So this is the mitotic activity, increased mitotic activity, abnormal mitotic figures there. Okay, or some cells, some ducts are showing the secretions, the calcification, microcalcification. So this is a typical picture of the invasive carcinoma, ductal carcinoma breast. Now comes to the invasive lobular carcinoma. 5 to 10% of breast cancer, mainly bilateral, multicentric, originate in terminal duct lobule unit. Same cell type as lobular carcinoma in situ. This is often mixed with the ductal carcinomas. You can get both the pattern in the same single patient. Does not insert a fibrous response, may be difficult to detect on palpation. The pattern is single file pattern of spread, also known as Indian file pattern. I told you there is a loss of E-cadherin, so that the cells are not arranged in the ducts, they are arranged in the single file pattern, the Indian file pattern in the linear forms. Prognosis similar to duct carcinoma, poor prognosis if left untreated or undetected late. Here you can see the Indian file strain of neoplastic cells. Cells are small and uniform with the dense stroma. Here there is no E-cadherin, no adhesion of the cells. So they are not arranged in the duct form or the solid nest form. They are arranged in the single file pattern, and they show the mild pleomorphisms and large nucleus, mild pleomorphism, increased mitotic activity. So this is a case of the invasive lobular carcinoma. Here is the more aggressive form and the high power view of this linear or the single file arrangement of tumor cells. Low nuclear grade means there is less pleomorphisms, lack of desmoplastic stromal response, there is less stroma, and you can see the cells are arranged in the typical line in the single file pattern. So this is a typical picture of the invasive lobular carcinoma. Next category is medullary carcinoma. Well circumscribed soft tumor masses. Prominent lymphoid infiltration is a very characteristic feature of this medullary carcinoma. If you get the malignant changes, malignant cells with excessive prominent lymphoid infiltrate, the diagnosis is medullary carcinoma. Paradoxically, despite relative good prognosis, most anaplastic tumor cells of any type. Okay, so tumor cells are very tumor cells tumor cells sorry for this. Here, let's start with medullary carcinoma. Is a well circumscribed soft masses, prominent lymphoid infiltrate. Despite the good prognosis is very good, but the cells are very anaplastic, the most anaplastic tumor cells of any type. No duct or glandular formations, solid masses are there. High grade nuclei, rare, less than 1% of the breast cancer. Here you can you see easily there is a lymphoid collection along with the malignant cells, the collection of the lymphoid cells in the medullary carcinoma. Next category is mucinous carcinoma, synonyms colloid carcinoma, also known as colloid carcinoma, occur in older women and is slow growing mass, well circumscribed, soft and gelatinous mass. Because of the mucin secretions, they have a soft and gelatinous mass. Well circumscribed masses, mucinous consistency. They are also rare, around 2% of breast cancer. Here the typical gross picture, if you get this type of the picture, greasy appearance of masses, well circumscribed greasy appearance, mucus is coming out on cut. So this is a typical picture of the mucinous carcinoma. Mucinous carcinoma, what you get in the islands of the tumor cells floating in the sea of mucin. So here is a typical, only the one line can describe this whole the microscopic picture. You get the pool of the mucin in which the islands of the tumor cell. Here you can see there is a pink tumor cell surrounded by the pink mucin. So abundant bluish staining mucin with a small group of cancer cells. This is the typical picture of mucinous carcinoma. In another hyper view, you can see this red arrow showing the malignant cells, vacuolated cytoplasm, pleomorphic nucleus, and surrounded by the mucin. Next category is tubular carcinoma. Extremely well differentiated ductal carcinoma composed entirely of simple tubules lined by single layer of cells. Can be confused with the benign lesion like a radial scars. Here, how we differentiate between the malignant and the benign. In the malignant cases, there is no myoepithelial cell here. If we stain for the myoepithelial cell, if we get myoepithelial cell lining outside the ductal epithelium, then it's benign. If myoepithelial cell lining is absent, when we labeled as a malignant. Extremely good prognosis, no death reported when less than 1 centimeter in size. 5% of the breast cancer. Here is a case of the tubular carcinoma, in which we discussed in a tubular adenoma, multiple small closely packed ducts are there without any secretions or nothing, and but myoepithelial cell lining are there. But in the tubular carcinoma, how we differentiate? Ducts lining, somewhere there is a single cell line, mild pleomorphism or no pleomorphism, and there is line, myoepithelial lining is absent. Then we say it's a case of the tubular adenoma. Here, when we stain for the, especially for the myoepithelial cells, normal duct on the left showing myoepithelial cell layer stained brown, and tubular carcinoma on the right. Here on the right side, you can see there is a lack of myoepithelial cells. Here, then we brought this is the left side. The 3 ducts are there. They are lined by the brown lining is there. They are lined by the myoepithelial cell. They are the benign. And here on the left, on the right side, you can see the small 3-4 ducts, and there is no myoepithelial cell lining. So we labeled as a tubular carcinoma. Next category is inflammatory carcinoma. Very painful condition. Diffusely, clinically what you get, diffusely red, swollen, hot breast, very warm surface because of the excessive inflammation. It's associated with very poor prognosis because of the excessive spread. Consider T4 disease. Skin biopsy show plugging of dermal lymphatics by the tumor cells. Okay. Closely mimic infection or cellulitis, but does not respond to antibiotics, often not recognized clinically. Diagnosis is very delayed because surgeon think or the clinician think that this is an inflammatory condition, the redness is there. So patient treated as a mastitis, and but after biopsy, when we do biopsy, advice for biopsy after antibiotic therapy, it's is spread in the deeper structures involved in lymphatics. So because of the delayed diagnosis, prognosis of the inflammatory carcinoma is very poor. Here you can see the lymphatic ducts filled with the malignant cells, so the lymphatic spread is more common. Here you can see the multiple lymphatics areas filled with the malignant tumor cells can invade the, and also they invade the skin surface. Tumor in the dermal lymphatics. What are the sources of roots of spread of breast cancer? First, the local spread. We already see in the various cases like it spread to the skin directly, involve the nipple like in the Paget's disease, and they ulcerate over the surface. They involve the deeper chest wall. So local spread outside or inside skin, outside the skin and inside the chest wall. By the lymphatic spread, lymph nodes involvement is very common along with the breast cancer. Local metastasis to axillary node, most common. Then they can invade to the internal mammary nodes, supraclavicular nodes also involved, but involvement of supraclavicular nodes is less common. Hematogenous metastasis, where the blood and can enter into the invade the lungs, liver, bones, and brain. So you have to remember this hematogenous spread to the lungs, liver, bones, and brain, 2L and 2B. Metastatic carcinoma in lymph node and lymphatics. On the left corner you can see the dilated lymphatic, and which is filled with the tumor cells, and here on the right side you can see there is a lymph node, excessive bluish, dark bluish is a lymphocytes, lymphoid tissue, and this pink area is a malignant tumor cells. When we see the slide of lymph node, we can see the tumor cells inside the lymph node, means it indicates that the invasion to the lymph nodes. What are the key prognostic factors? First is stage of tumor. Tumor size. As a small size less than 2 centimeters, and the stage T1, then 2 to 5 centimeter T2, or more than 5 centimeters is T3. Then axillary node status. Single most important prognostic factor, predicted distinct metastasis. Tumor grade, we have to be grade the tumor well differentiated, moderately differentiated, or the poorly differentiated, G1, G2, G3. Margin of resection, local recurrence likely if tumor in margin. If tumor involves the margin, then local recurrence can occur. Then estrogen and progesterone receptors, important for both prognosis and treatment. ERPR receptors, negative tumor have worse prognosis. ERPR positive tumors respond to anti-estrogen agent like tamoxifen, raloxifene, aromatase inhibitors. So ERPR receptors are advised to the patient. If the ERPR positive, then prognosis is good because they respond to the anti-estrogen agent. We have the various good chemotherapy for this. If the ERPR negative, then the prognosis is poor. This slide showing the brown nuclear staining, they are showing the estrogen receptor immunostain. So it shows the ER positive. Next marker is HER2 new, also known as CRB2, human epidermal growth factor 2. Human epidermal growth factor 2 gene is amplified in 25% of breast cancers with associated protein overexpression. HER2 amplified tumors respond to treatment with anti-HER2 antibodies, Herceptin. Okay, so Herceptin, if the HER2 new is positive, then we can advise this Herceptin. This is the immunohistochemistry and the FISH by which we can detect the HER2 amplification. Here this is a positive for HER2. In this immunohistochemistry, you can see the staining, membrane staining, and then here we can see there's a FISH showing the HER2 amplification. There's a green color. Molecular subtype of invasive carcinoma. We advise the patient ER/PR receptor and HER2 receptors. Why we advise? Now we can a molecular subtype to this cancer on the basis of ER/PR and HER2. If patient has a ER positive and HER2 negative, this is known as luminal type of the cancer. Most common 50 to 65%. Is ERPR positive and HER2 negative, low proliferation is there, then this incidence is 40 to 50%. And ER positive, HER2 negative and high proliferation, then again this ER positive and HER2 negative, we divide into two categories, low proliferation and high proliferation. We do the proliferative index in this patient. If the low proliferation incidence is 40 to 50%, prognosis is good, and high proliferation rate incidence is 10%, prognosis relatively poor. If HER2 receptor positive, ERPR positive or negative, 20% cases we get this, the second most common category. If ERPR negative, HER2 negative, incidence is 15%. This type is known as basal like triple negative. Okay. Then AJCC staging for breast cancers. Here there's stage 1, 0, 1, 2, 3. We divide the cancer into stage 1, 2, 3, and the 5-year survival is also here. The stage 0 is known as in situ carcinoma, tumor in situ. Stage 1, if the tumor size is less than 2 cm. Stage 2, if the tumor size is 2 to 5 cm with the nodal invasion. Stage 3, if the tumor size more than 5 cm with supraclavicular and intraclavicular lymph nodes are involved. And 5-year survival in stage 1, 5-year survival is 92%. In stage 0, 5-year survival is 92%. Stage 1, 5-year survival is 87%. Stage 2, 5-year survival is 75%. And stage 3, survival is just 46%. So it indicates there is a prognosis also. Stage 0, carcinoma in situ. Stage 1, 2 and 3, size less than 2 cm, 2 to 5 cm, more than 5 cm. So you can remember like this. Another prognostic factor is lymph node status, lymph node size and grade of the tumor, grade 1, grade 2 and grade 3. Histological type we already discussed, which are according to the good prognosis and poor prognosis. Hormone receptor status, if ERPR positive, there is a good prognosis, ERPR negative, poor prognosis. Lymphovascular invasion, if lymphovascular invasion is present, then poor prognosis. If absent, then good prognosis. Proliferative rate and aneuploidy DNA contain, if the more proliferative rate, then poor prognosis. HER2 new expressions in so poor prognosis. Gene expression profiling is also done for this, so detect the prognosis in the patient. So that's all for this breast pathology. Okay, thanks for your attention.